Particularly excited that, and this meeting is being recorded. Awesome, Suzanne. Excited that you're joining us today. So I'm a clinical psychologist, did my training at the VA, my internship, and then a HSR&D fellowship as well. A few people I was able to connect with and work with through that experience. I see on the call, Greg and Simon, I met through that. Really wonderful training experience, and became familiar with many of the great opportunities for rollout of digital resources within the context of the VA, as sort of the nation's largest healthcare provider, and also one that has dedicated a number of resources to developing some of these tools. A gap that many of us are all faced with, especially now, some of the work that we've done with other MHealth tools is sort of figuring out how to take these promising and exciting tools and to really get them into the world and train clinicians how to use them and become facilitators, become clinicians who are adept at using them. So we were very excited when some of our colleagues at the VA brought to our attention the work that you've been doing. And so excited to hear more about it today. It's relevant to a number of kind of very closely related to the work that many of us are doing right now. So without further ado, I'll introduce Dr. Pearl McGee-Vincent. She's a clinical psychologist and acting deputy director for the National Center for PTSD, Dissemination and Training Division in Menlo Park, California. As the director of the practice-based implementation network within VA, she manages all aspects of a large and growing infrastructure of VA providers, staff, leaders, and researchers collaborating with DoD partners to improve adoption of technology-based practices in mental health treatment for veterans and service members. She currently leads a 2-year National Joint Incentive Fund Quality Improvement Project titled Expanding Reach of VA DoD Mobile Apps to Improve Coping and Reduce Suicide Risk, which includes the development of a safety planning mobile app. So we're very excited to have her here, and I'll hand it over to Dr. McGee-Vincent. Thanks for joining us.
Thank you for having me, and thank you to Dr. Greg Rieger for making the connection. Let's see, I emailed my slides in, so I don't know if I need to upload them or if somebody else can get them on screen for me.
Yes, I can share them.
Thank you so much.
One moment.
If Pearl wants to control them, though, I think it's probably maybe we should just authorize her to share her screen, and she can.
She can also do that. It's up to you.
Where did let's see. It might be easier for you to do it because I don't know where I saved these guys. Let's see.
Okay.
Yeah, just maybe if you don't
yeah,
mind me.
Absolutely.
The next slide thing.
Will do.
Thank you. Yeah, Zoom doesn't work on our VA computer, so I'm on my laptop, but the slides are on the other laptop. Anyway, thank you again for having me. And I'm actually joined by my project manager, Dr. Andrea Jameson is on the call as well, and she will be able to chime in and help me answer questions. I'd like this to be as casual as you'd like it to be, so please feel free to interrupt and ask questions. And this project has a lot of details to it, so there's a lot of different rabbit holes I could go down, and probably things that I'll miss. So feel free to, if you want elaboration on any particular aspect, please stop me and interrupt and ask questions. I will say that I did not do my internship at VA. I did my internship at Napa State Hospital in California. So I have a background in my clinical training with folks with SMI, and I did a SMI focused clinical postdoc in the VA. So I was excited to read up on you guys a little bit and learn about what you're doing for that population in terms of tech. So very cool. Let's go ahead and advance the slide. Just a little bit really quick about the National Center for PTSD. So we are part of the VA. There's 7 divisions total around the country. As was mentioned, I'm part of the Dissemination and Training Division in Menlo Park, currently working from home in San Francisco during the pandemic. But our mobile mental health apps team is part of the Dissemination and Training Division. And so the work that I do is very much related to our mobile apps initiatives from the Dissemination and Training Division. let's go ahead to the next slide. So the team has been developing apps since 2011, starting with PTSD Coach, and then PE Coach in 2012, which Dr. Rieger is very much involved with. And since then, it's been a flurry of app development. And most recently, in the past year, the team developed COVID Coach in response to the pandemic. That's an app that is for anybody dealing with stress related to the COVID-19 pandemic. We also developed Insomnia Coach, which is a self-guided version of cognitive behavioral therapy for insomnia. Couples Coach for relationship stress. And then we recently, just very recently, and within the past couple of weeks, released Vet Change 2.0, which is a new version of an older app for veterans with PTSD and alcohol use disorders, as well as Beyond MST, which is for those for survivors of military sexual trauma. Next slide, please. And I see there's something in the chat. It's Andrea saying hi. Okay, so we usually divide our suite of mobile apps into two main broad categories. One of those being the self-care mobile apps, or those that can be used by anybody, whether you are engaged in treatment with a trained clinician or are using an app for self-management. So the apps you see on this screen, I won't go through them one by one unless anybody has questions or wants to hear about a particular app, but this is our current suite of self-care mobile apps. They are all available publicly. I think by now all are available on both in both marketplaces, so available to Android users and iPhone or iOS users. It's taken a little longer to get up to speed on the Android devices, but that's been a highly requested feature, is that these be available to anyone with a smartphone, regardless of what kind of device they have. So we've worked hard to get parity between the two platforms. All of the apps are private, meaning that they do not communicate any identifiable information about the user to the VA or to anywhere. We don't sell any information, track or sell any information to third parties, for example, as you might see in apps developed in the private sector. Of course, not having access to that data is a strength and a weakness in terms of kind of wanting to know more information about our end users, but we can recommend these apps in good faith to veterans and assure them that that nobody is going to be prying or buying or selling their personal data. All of our apps are evidence informed, so they're based on the latest and greatest research to the best of our ability. They're reviewed by subject matter experts. They are not considered interventions, evidence-based interventions in and of themselves, but they can be used for self-care or to supplement treatment. So we do get that question a lot of, why don't you guys do more outreach and recommending of apps that are not VA or DoD created? And those are some of the reasons why, because we can really stand behind the privacy and quality assurances of VA apps. We do have a lecture archived on our PBI Network Lectures series website of actually John Torres talking about the app evaluation model by APA and kind of things to consider if folks in VA do want to incorporate apps that are not VA developed, sort of what the decision-making process they should go through around that should be. Next slide, please. And these are our treatment companion apps. So these, again, publicly available. Anybody can download them in theory, but they were really designed to accompany evidence-based treatment and protocols ACT for acceptance and commitment therapy, CPT coach, which is undergoing a long overdue update. That's a pretty aged app. PE coach, Stare coach is also undergoing an upgrade, and Stay Quit coach, which is for folks who have gone through smoking cessation and want to maintain their gains from that. Next slide, please. So up until, so I joined the National Center in 2012. I didn't have anything to do with mobile apps until 2017. I was working on other implementation initiatives and doing a lot of clinical care as well. In 2017, I joined with the mobile apps team out of a recognition that we were doing a lot of good work with developing apps and not a lot of work with engaging with the field, educating staff on how to use the apps, informing them that they exist. So the Tech into Care initiative was really a hybrid kind of marketing training initiative with where we developed based on kind of feedback from folks in VA in the field, resources that they would need to better uptake and use mobile mental health apps. So we developed resource sheets, trainings, videos. You see there just a screen capture of a YouTube video. So we have, and I can paste these in the chat when I'm done, but we have a YouTube playlist with just mini videos giving an overview of each of our apps. It's provider facing and veteran facing. So you can just get that quick overview of how the app works. We also did a CE archived training that's me playing the therapist and modeling different skills with incorporating mobile mental health apps into care. We started with a pilot of just, I think, 28 clinicians where we trained them the basics on our suite of apps, things to consider when introducing and using them with veterans, and just said, okay, go use them for 12 weeks and come back and tell us how you use them and what you did and what you learned. And we did a lot of qualitative interviews. And interestingly, we found that they were using the apps in different ways across the continuum of care. So at the specialty PTSD treatment level of care, for example, they were more apt to use the treatment companion apps as an adjunct to that treatment. But then there were lots of cases of staff clinicians integrating apps as, in one session of a therapy protocol where they would just say, okay, I'm going to introduce you to AIMS for anger management. And this is something you can choose to use or not use on your own, but it was kind of a light touch introduction. It wasn't like the app was central to the main presenting problem or the main focus of therapy. And then we, on the lower end of the continuum of care, we had just lots of examples of one-off introductions to apps. So people who were maybe introducing apps on intake as a, check out PTSD coach, your first appointment for evidence-based treatment for PTSD isn't going to be for 2 weeks, but I'd like you to check out this app in the interim and, start getting some coping, start getting some psychoeducation, things like that. Which got us kind of thinking, these apps could really not only be treatment companions or supplements to care, but potentially serve as a bridge to care for those who are might not follow through with an intake, but might at least leave with some resources if they only have one visit, or be introduced to an app in primary care by their provider, and at least walk away with access, push button access to the crisis line and some basic information for those who, the majority of folks with PTSD or who could benefit from PTSD treatment aren't landing in PTSD specialty care. But they are being seen in many cases at other points in the VA healthcare system. So kind of looking at what are all these touch points, and how can we utilize clinical and non-clinical providers to use apps as a way to potentially engage folks in self-care for those who are subclinical, or as part of a referral to a higher level of care, et cetera. And if you could advance the slide, I think I have a little animation to one of our most popular resources, which is this prescription pad, which we did steal from DoD. This was their original idea, but we've updated it and added all of our most recent apps. So this is something that that staff have reported really appreciating having just out on their desk as a reminder to recommend apps, and as something they can, if they're in an in-person visit, can physically tear off and give somebody a recommendation for how to use a particular app. We also have on here, in addition to mobile apps, our online training programs that are accessible to folks who might not have a smartphone but can get internet access and get, for example, our Moving Forward problem-solving therapy program. Okay, let's keep going. As part of that initial pilot, we developed a community of practice where the participants could come together, share lessons learned, talk about how they were using apps, problem solve barriers. And this has continued ever since and actually grown, and we're getting upwards of 100, sometimes 200 participants each month. We have, this is offered within VA, but I'm sure those of you who aren't affiliated to VA could pop in if you're interested. But we have members of our mobile apps development team giving updates on the latest and greatest for our apps. So for example, in May, we will have an update on the forthcoming Stair Coach app and the updated CPT Coach app. So sneak preview as to what's to come, and some last minute opportunity for input from the field. And then we actually have folks from our project presenting on how they're incorporating apps into their work at their facility. Now, one of the interesting things that we did notice in this community of practice as it began to grow, and again, the intention really being to have kind of a feedback loop between our app development team and the providers and staff on the ground that are implementing this stuff. One of the things that we noticed is that we would get participation from chaplains, dietitians, audiologists, people that were kind of outside of the disciplines that we typically think of as offering mental health care or treatment. And so we were really interested in that. And that's kind of what fed the idea of, people are introducing apps all along the continuum of care and in all kinds of settings. And this is a really good opportunity to equip non-mental health providers with self-care apps and with a little bit of education about how to introduce them responsibly, and potentially reach some of those veterans who otherwise wouldn't have access to or awareness of these types of tools for self-management. All right, next slide, please. And I'm just going to check the chat real quick because I see a couple. Oh, thank you. Andrea is helping me to post resources there. All right, so this brings us to our current initiative. The Joint Incentive Fund is a pot of money that is available to VA and joint VA and DoD healthcare system initiatives that are aligned with the mission of both healthcare systems. So for example, suicide reduction, access to care, et cetera. It's specifically money that is not for research. So it's for quality improvement, program evaluation, healthcare operations, but it's not a traditional grant funding mechanism. But we were able to procure funding for a GIF, as they're called, and this is typically a 2-year pot of money. We got a little bit of an extension. Our DoD partner was originally, so there is a parallel initiative happening in DoD also to expand mental health technology to service members. I'm going to focus on the VA side of things, but just so you know, we regularly collaborate with DoD, and that side of the initiative was originally led by Christina Armstrong, who many of you may know. She was part of the Connected Health branch in DoD, and then she actually came over to VA. And so then my partner in DoD was Dr. Julie Kinn, who some of you may also know. She just took another job, so I've lost track of who the DoD partner is in this, but just know that that this is a cross-departmental project. So I will explain a little bit about what we've been up to. Just quick disclaimer, this is still ongoing. Our end date is December 31st, 2021. And so I'm not going to present outcomes data. I may have to come back to do that, but I'm more going to focus on kind of process and the what and the how of what we're doing in this project. So if we could go to the next slide. Just really quickly, this is our team. So all of the tech into care stuff that we were doing, provider outreach, education, the videos, the marketing, until we got the GIF funding was just done by myself and Catherine Uhas in the bottom row there. The GIF allowed us to hire 3.5 facilitators who you see in the top row, Tim, Colleen, Jean, and Lauren, program assistant Sharon, program manager, Dr. Jameson, who's on the line, and Maggie McIntosh, who's our eval lead. So really expanded our scope and ability to really get things going. So next slide, please. All right, so our main objectives for this GIF project were firstly to develop a digital safety plan. So in VA, and beyond VA, there's something that is used as part of suicide prevention, which is called the safety planning intervention. And up until this point, typically in VA, this is a 6-step intervention that's paper and pencil based. The provider goes through it with the veteran. Often they're not really robust. If you go through the electronic health record and look at the kinds of safety plans that providers have developed with veterans. And at the end of that discussion, the provider would have to print out this paper copy of this plan for all of the things that the veteran is going to put into action. If they're experiencing warning signs, if they need to engage their support network, if they need to call crisis services, and they give it to them on a piece of paper. If they're face-to-face or if they're having a telehealth visit, they stick it in the mail. Maybe it gets to the veteran, maybe it doesn't. Maybe it's on the veteran's person when they need it, maybe it's not. So we just thought this was a really good opportunity to create the option of having a digital copy of the safety plan, since we have the capacity to develop apps and app features. And that this could also allow incorporation of coping tools from existing apps. So we developed this and put it in the existing PTSD coach app. More on that in a minute. And then the second big part of this initiative was to implement this national project to expand veterans' access to mobile mental health apps. And how we did that was to establish a champion, or what we called MHealth Specialist, at one facility per VISN. So a VISN is a VA, it's like a region. So the VA is carved up into 18 regions, and that MHealth Specialist would be responsible for championing local MHealth implementation efforts and sustainment of MHealth adoption as defined by that facility's implementation plan. And the second aspect would be to educate the mental health staff there at the participating facility, as well as staff outside of mental health services. So in order to be eligible to participate, the facility had to pony up at least 20 participating staff, and at least some of those had to come from mental health, and at least minimum of one, but ideally some cohort of non-mental health folks. And those folks would participate in training on how to implement mobile mental health as relevant to their role, and kind of make a commitment to not just learn the skills, but to use it in their work and to introduce at least a guideline of 25 veterans per year going forward.
Pearl, can we pause for a second and maybe, are you okay to take some questions?
Absolutely.
So maybe you can say a little bit, some of us are very familiar with the VA system, but it does function differently from other fee-for-service agencies or healthcare systems. And so there are a lot of things that you're already describing here that seem to be capitalizing on that structure. Can you say a little bit about how, when you say, when you're asking the sites to pony up, what does that mean in terms of the internal capacities and the decision makings that are somewhat independent of a need for CPT codes, right, and other things? And so maybe you can elaborate a little bit on that.
Yes, so we did a lot of formative evaluation with the sites prior to enrolling them, and we used sort of a top-down, bottom-up approach. So we interviewed different potential stakeholders at the facility and made sure we had buy-in from the leadership, who would be basically allowing time for folks to participate in the 3 to 4 hour training and the surveys. We did assure them that the MHealth integration that we would be training them to do would be integrating MHealth into what they're already doing. So it wouldn't necessarily be adding additional time for the individual staff member. For the MHealth specialist, who would be doing more trainings and more outreach activities and engaging with the external facilitator, they would need buy-in from their leadership to offer up that time of at least an hour a week. And oftentimes that was negotiated because that individual already had protected time for research, for admin. They were what's called the local EBP coordinator, so they kind of had protected time to do extra projects. So we packaged it as, this isn't going to cost you money or time necessarily above and beyond the training and surveys for what your folks are going to be having to do, and that it will hopefully add value in that you'll be reaching additional veterans with resources to support their care and for suicide prevention.
And then there's an ongoing commitment of time for setting people up and responding to technical troubleshooting needs or other issues along the way. Is that right?
So, so back at our kind of hub in Menlo Park, we have our mobile mental health apps team and SharePoint site. So, so any participant in the project can email us at any time with technical support questions or for help of any kind. And we also take the most commonly asked questions. For example, how do I acquire my veterans don't have tablets or smart devices. How do I acquire a device for the veterans so that they can participate in this? So we will compile the information and put it on as a discussion board post with all the appropriate links on our SharePoint site, so that anybody else with that question going forward, we can direct them to that that information. but we are available to do hand holding. The MHealth specialist doesn't have to, the local champion / MHealth specialist doesn't have to hand hold everyone locally, or isn't expected to.
Thanks. That we're of course, some of us are working on projects, so there are many parallels and slight differences in the model. So this is all very informative for us.
Okay, yeah, definitely keep asking questions, because there's a lot of nuances and a lot of things that are probably VA specific, and a lot of resources that we have that that other folks might not have built in. I think we can go to the next slide. Okay, so just really quickly, this is our safety plan app module. This was developed with a lot of input from various stakeholders, including Barbara Stanley and Greg Brown, who are the originators of the safety planning intervention. The main piece of feedback that we got on this was, why is it buried in PTSD code? If my veteran is in crisis, they need to just open their phone and launch their safety plan and get in there and use their plan. This really needs to be a standalone app, and we completely agreed. And so we are in the process of developing that now, and that's part of the reason we were able to get an extension on our GIF. Actually, the main reason was that our DoD partners were lagging behind, and they got us a joint extension, and then we're able to capitalize on that by using some of that time to also develop this app. And we're currently doing a lot of user testing and interviews to help inform an improved version of this tool. Of course, taking into account that, again, as our apps are available in the wild, wanting to build in everything we need to build into the app, so that if somebody is so motivated to create a safety plan on their own, or with the support of a loved one and not with a provider, that the app contains all of the information in a user-friendly way that they would need in order to do so. All right, next slide. Okay, so we did end up enrolling 19 sites. That's one per VISN or region, plus a bonus site. So we had 2 in our region. We ended up having 32 MHealth specialists or champions. So most sites ended up with a co-MHealth specialist or a deputy MHealth specialist, and part of that was to split the labor and make it doable to accomplish everything that they wanted to accomplish in their implementation plan. And also some found that with the participation from both mental health specialty settings, which are often siloed, and non-mental health, it helped to have an MHealth specialist in both settings to target both populations. And then the staff trainees or participants, we called them MHealth Ambassadors to give them a special title and a badge as well. We find that a lot of just reinforcements along the way can help a lot. So folks were adding these little badges that we created to their signature line in their emails. We sent certificates to folks for participation, but we really only required, or we're targeting 360 staff initially, with this kind of, and I say this completely jokingly, this kind of pyramid scheme model of sustainment, whereby the MHealth specialists would bring in an additional at least 20 staff per year by training them and bringing them into the network of MHealth ambassadors year after year, so that number would continue to grow via sort of a train the trainer model. But we only anticipated starting with about 360 or 380 initial staff, and people were more excited about it than we anticipated. So we got 1,100 staff participants, and by and large, that was voluntary. So we'd work with we'd find an MHealth specialist or champion at each facility. We'd get the leadership buy-in. We'd get some clinic buy-in, and then we'd help them recruit participants locally. And only in 1 or 2 cases did a site say, okay, we're mandating that everyone in our clinic be part of this training. It was usually people raised their hands to sign up and said, yes, this is something I want to learn and something I want to implement in the care that I provide for veterans. Let's see. Next. Oh, and just to say, so these site visits were to take place in calendar year 2020. So our first one was in January 2020 in St. Cloud, Minnesota, which is not a great place to visit in January because it's freezing cold. We got through 3 in-person visits before the pandemic hit. And so we had to make a rapid switch to virtual. So the remaining 16 visits in calendar year 2020 ending, I think our last one was the beginning of December, were all virtual. So virtual training, virtual leadership briefings, virtual implementation planning sessions. So it's kind of an unanticipated shift there that we had to make. Next slide, please. Okay, so what's missing from this timeline is that, as I mentioned, there were several months of pre-implementation work that the external facilitators did with each of the sites, sort of engaging potential stakeholders, interviewing folks, figuring out which types of staff might be engaged, which types of programs. Telehealth, for example, there's a program called Whole Health, which was relevant to the project, talking to different folks, designing a custom implementation plan that might be relevant to that site, and getting everyone on board before signing up. And then there was 2 weeks prior to the site visit, there was a baseline survey that was administered. On the day of the site visit, this participating staff took part in a virtual training or virtual training for most of the sites that I'll describe in a moment. Right after the training, they did another survey. There was a 90-minute implementation planning meeting, which I'll go into a little bit more, as well as briefings with site leadership that took place at the start of the site visit day to kind of orient them to what was going to take place and to have introductions, and then an exit brief at the end of the site visit to discuss decisions that were made during the implementation planning session, as well as ways that leadership could support implementation. Then each site had a 12-week active implementation phase during which they were the MHealth Ambassadors or staff participants were to use what they learned. So the idea is not just to train and pray, but to train and actually have folks employ the knowledge in practice. They were also surveyed during the active implementation plan, just brief surveys on whether and how many veterans they were introducing apps to during their week. The MHealth specialist would have regular meetings with the external facilitator from our team regularly to check in about the implementation plan and progress for help mitigating barriers, et cetera. And then at the end of the active implementation phase, there was a survey as well as qualitative interviews with the mental health specialist or specialists, as well as the facilitators. And then sustainment involves continuing to implement their plan to introduce apps to veterans. We did a 3-month report to leadership, which included their pre and post survey data, summary of how things went, what's still to be accomplished in the implementation plan, and again, just really giving leadership an opportunity to reinforce the MHealth specialists' efforts and to for them to ask for anything else that they might need to help with ongoing efforts. And then again, the sustainment plan includes training additional staff at the facility each year. So it continues to expand. Next slide, please, unless there's any questions on that one. All right, so the training was made applicable to both clinicians and non-clinicians. So everybody got trained in app functionality. We got feedback that people really want to go dive inside the app, see how they work, understand the functionality, be kind of bought in themselves before they introduce them to veterans that they're working with. So we did demos of some of the self-care apps, including PTSD Coach with the new safety plan, the mindfulness coach app. A lot of our audiologist participants use mindfulness as part of progressive tinnitus management. So I didn't mention this before, but we really wanted to involve audiologists because a lot of veterans have hearing issues from their service, and a lot of them pass through audiology, and they can show up in audiology without even having been screened in primary care, where they normally would be screened for mental health issues. So audiology is another one of those touch points where folks can be referred to mental health or screened and or potentially given resources for self-help for mental health needs, even if they're, again, never going to set foot in mental health. So a lot of audiologists interested in mindfulness coach, and then the Aims for Anger Management app. And then we, in the last hour of the training, which is targeted at clinicians, we went through the treatment companion apps, and they could select which treatment companion apps they were most interested in, and break out into breakout rooms and get special training in that the particular apps that were relevant to the kind of treatment that they are providing. We provided use cases and examples for using the apps across the care continuum, examples of overcoming barriers to use. For the clinicians, we went through kind of the clinical integration steps, including assessing appropriateness, obtaining informed consent, privacy, etc. Documenting in the EHR, we did encourage everyone to document in a particular way when they recommended an app. Again, we don't have that back-end data to say whether the staff that we trained recommended the apps to as many veterans as they said they did. But we hope to eventually have the capacity to go back in and do some natural language processing and comb through and see if and to what extent and how folks were recommending apps based on their documentation in the medical record. And then we also talked in the training about their commitment to putting what they learned into practice, to thinking about use cases in their particular line of work and how they might introduce apps to veterans, whether that be part of an evidence-based treatment protocol or other form of psychotherapy, or part of a one-off primary care visit, or a peer support specialist kind of recommending an app and saying, hey buddy, this is how I used it and how it worked for me. Are you interested? Can I show you how to download this thing? So really kind of making it relevant to their work, and also training that apps aren't going to be for everyone. We don't have enough evidence to say, yes, you should do it and you should use it in this way every time, but to say, make it a choice, make it at least available to the veteran. They can say, nah, I'm not interested, and we're not going to force this on anybody, but to equip these folks with enough knowledge to talk about the potential benefits of using apps. All right, let's go to the next slide. I'm just looking at the time. So implementation planning was a big, this was again, a 90-minute meeting with key stakeholders from the facility, as well as the external facilitators. And prior to the visit, they developed a big document with all the decision points for the stakeholders to go through around, okay, how are we going to make MHealth an integrated part of the care we provide? How are we going to spread the word to other programs? How are we going to expand the reach of apps throughout the facility? Are we going to do direct to veteran outreach? Can we involve public affairs? Can we put app demo videos on the monitors in waiting rooms? What are existing resources we have that can support implementation? How can we talk about apps and incorporate them during new employee orientations? And then once they've designed the custom implementation plan for how apps are going to be integrated in that facility, how to maintain staff momentum for practice changes. Because what always happens is in the implementation planning meeting, everyone gets so hyper and so excited and motivated for like how they're going to use this new innovation. And then, reality gets in the way and other, priorities get in the way. And COVID definitely kind of got in the way, but also kind of incentivized people because there was so much more telehealth happening and people saw the value of apps in that modality. And then also planning for sustainment over time of the practice changes that they make at their facility. Let's go to the next slide. Oh, that's just a screenshot of what an implementation plan looks like. So the external facilitator meets with the MHealth specialist team or stakeholders, or sometimes there was a whole work group at the site, and they revisit the implementation plan and look at the status of the different items and whether there are any barriers and how to troubleshoot them, and offer kind of motivation and reinforcement and problem solving along the way. And I think in the notes in the actual PowerPoint presentation, and I can also paste it in the chat when I'm done, is a link to the implementation facilitation manual that we use, which is by Joanne Kirchner at the Mental Health Query in VA. All right, next slide. Okay, this is just a breakdown of our 1,100 participants, kind of the different disciplines that we saw. And so a lot of diversity here, including a lot of other. All right, let's go to the next slide. So this is the dotted line. It was kind of our anticipated reach to veterans. If we had stuck to our, recruiting 360 staff participants and those each recommending apps to veterans, how many veterans would be reached in 2020. And based on the numbers, they were reporting back to how many veterans they were introducing apps to and the numbers of participants that we had. If we blew 2020 out of the water with a reported 32,551 encounters with veterans involving a recommendation to use a mobile mental health app. And if our train the trainer model were to work as planned, we would anticipate seeing this this continue to grow at this rate, with a potential 500,000 veterans being reached with apps by 2023. So that's aspirational, but just to show that we way outdid ourselves with reach. Next slide, please. Just some resources for you. Again, anyone, veterans, members of the community, we're not just limited to veterans. Our apps are accessible and available to anyone, and anyone using the apps can email us at mobilementalhealth@va.gov. You'll get me, you'll get our dev team. One of us will respond. We respond to every single email eventually. Report bugs in our apps, offer suggestions for new apps, questions, get added to our mailing list to receive app updates and invitations to trainings. Here's some additional links to our website. The Tech into Care SharePoint is only accessible behind the VA firewall. The lecture series is on the next slide, and I'll talk about that briefly. There's a public website where you can order hard copies of the RX pads, posters. We also have a lot of swag, which seems to help motivate people. You know, they like getting little tchotchkes and things with our logo on them. Let's keep going. Yep, here's our monthly lecture series. And unlike the Tech into Care Community of Practice call, this is one where we really invite folks in the field to present on technology above and beyond what we offer in VA, as well as experts from VA. So for this one, we offer CE units. I'll be presenting, it looks like, on August 11th. Hopefully we'll have some data from the project to present by then. But this is something that you all are invited to attend if there's ever a topic that's interesting to you or you want to present. Please reach out. And I think we're coming to the end. Let's see. Yeah. All right. I didn't realize that was going to take so long. So sorry to leave only 4 minutes for comments and questions, but you can always email me after the fact if you if something wasn't clear or you have follow-up questions or want any consultation.
Well, for starters, thank you very much. That was a terrific overview of everything you've done, and it's quite an impressive endeavor. And the fact that you so dramatically overperformed with your reach that's really notable, right? And so maybe just one question on my side, you know, the gaps between what you anticipated or hoped for and what you wrangled up over the course of the project, were there areas where that caught you off guard and required some scrambling and preparation to address the need of a larger interest and user base, or were you was the infrastructure, people, resources, was all that in place sufficiently to accommodate?
I'll let Andrea chime in if she has any additional comments, but I don't think we had to scramble. You know, we had to make some adaptations. For example, in some sites we did multiple training days instead of just one, so we'd extended over time. We were lucky to have this additional staff during this project because we could have people mailing out resources and responding to requests for help and things like that. But I think the challenge for us will be in sustainment when we go back down to being a 2-person ship. To keep up with the demand, I think will be challenging. It'll be a good problem to have, though.
I was just going to add that, hi everyone, that some pleasant surprises were just the demand from the non-mental health staff. And so, for example, we had a lot of interest from dietitians, which we hadn't anticipated. And in one site, I think we had a dietitian who was a co-MHealth specialist. So we, and by we, I mean Katie Uhas is not on the call today, went through the whole procedure to be able to offer continuing education credits for dietitians with our lecture series. So that's going to be starting soon. So there are things like that we didn't anticipate. I think we had more pharmacists than we anticipated, and a lot more groups outside of mental health that were really hungry for this information and these resources. And it's hard to say how much the pandemic influenced these numbers. You know, obviously we only had 3 site visits beforehand, but we do think that was a significant contributor to why we had why we just blew away our projections, at least in part. And agree with Pearl with what she said in terms of we'll see as when this project, the funding for this project is over and we go down to a smaller team, if we're able to sustain it. But it's been a what's the word I'm looking for? A pleasant surprise all around, and that we've been able to keep up with it so far.
Coming right up to 12 o'clock, I want to I don't know if folks have, I'll be respectful of folks' time, wrap up on time, and oftentimes these things run long. Thank you again so much, both of y'all, for joining us, Dr. McGee-Vincent, Dr. Jameson.